Sorry about that. So my name's Miranda. I'm one of the associate PIs at King's College Hospital, and we're just going to give a very sort of brief overview about the SepTiC trial that we're running here. And Emma is one of the lead research nurses, and she's going to jump in with any additional comments. So the SepTiC trial is obviously a double-blind trial that is essentially looking at sepsis in critically unwell patients and trying to optimize management. If we can just move this slide on, do we have control of that? Okay. And it's looking at, which I think most of you probably know, three main arms, which is antibiotic stewardship. First one, and the second one would be conservative fluid therapy. And the third arm is whether GM-CSF compared to placebo improves outcomes in a high-risk subset of patients. And that is the arm that we are specifically focusing on at King's Hospital, mostly because we thought that we'd be able to achieve the objectives of the study with this arm, and that we didn't feel we would be able to, we had the patient population to be able to achieve 1 and 2. So the third one is the one that we are focusing on, and that's going to be the focus of this talk. We'll just slide switch, please. So just to remind everyone, which I think they probably know, is about the inclusion criteria. So an absolute lymphocyte count of less than 1.2 on two consecutive results, and you've got to be either intubated, mechanically ventilated, and expect to be on that for at least 24 hours, or you can have 2 organ supports. So that could be vasopressors and renal replacement therapy, or vasopressors and high flow nasal oxygen. I won't go through all the additional exclusion criteria, but we were talking earlier about some of the ones that we found mostly, and that's probably the one that applies, is the first one, more than 120 hours, 5 days since ICU admission. We don't often find patients with a total white blood cell count of greater than 50, and they're not really often on GM-CSF already. So it's probably the first one that's most applicable in this hospital. And there's not that many patients either with a weight above 125. They tend to be between about 70 and 80. If you could just go to the next slide.
And it's worth noting that our pharmacists have actually done a lot of work looking at actual patient weights, not just nurses kind of saying everyone's 65 or 80 kilos, because we know that that can be a critical care thing across the board. So it's surprising that I would have assumed that more patients would have been over 125 kilos, but we're not actually seeing that in the patient population.
So how do we recruit patients? I think I was thinking about this, probably 6 main ways, which I will go through each one individually, but there's a sort of brief summary of what I'm going to talk about. So if we go to the next slide, the first thing would be the critical care research team. I think we're very lucky at King's to have quite a large critical care research team. That is the 6 of the members, I think there's 7. And so what they are able to do is support the departments, and once patients have been identified, the research team can actually help with administering drugs, following up with family discussions. And so I think the number of people involved does help to recruit patients. The second one, if we go to the next slide, is that in addition to the research team, where everybody can be involved in all the studies, there's also a lead nurse, which is Emma, and then there's 2 associative PIs. So I'm one of them, and I was in critical care, and now I'm on the medical wards. And I think that is helpful for when patients come in, either on the medical take, highlighting patients, or also if patients are stepped down to the wards. And if they also, while on the wards, if they suddenly become eligible, then just having people in different places identifying patients helps in the recruitment. If we go to the third one, and I think this third one is probably very lucky at King's, is that we've got weekend support. So 7 days a week, there is a research team present at King's, and that means just that if patients become eligible, then they're not hindered by the weekend in terms of administering medications. I think if we didn't have weekend support, then potentially some consultants, ICU consultants, would maybe object just because weekends become very busy and trying to administer medications. So weekends is a little bit trickier. So yeah, it was 7 days a week. Yeah.
So, and essentially from a research nursing perspective, we work Monday to Friday. But what we've agreed to do, so I as the lead nurse and some of the other team have agreed to support SepTiC, because what we found is we were supporting administering medications, we were supporting screening, we were supporting discussions around it, and then suddenly our clinical staff would find that they had an IMP that was to be given over the weekend, and just knowing that we're on the end of the phone or on the end of our generic email and just checking in, and our PI is phenomenal, Phil, who's on the call, and he will also be maybe clinical or checking in as well, and the team just knowing that they've got that backup support, so that if we were to see any abnormal results in our bloods or anything like that, then we're on hand and we're always keeping an eye on these patients. So that's just an added extra that we've given SepTiC as a blinded IMP study that we wouldn't necessarily have done had it not been. That's where the weekend supporting comes in.
If you go to the next slide. So screening patients. So we've got Epic at King's, and we've also got Epic Message. And I think in every morning the research team do screening of all the patients that are in ED. And we have a shared Epic messaging group where patients are highlighted to each other and to see if they're eligible. And then the PI, so Phil, will automatically log eligibility, and then he often goes to the ICU bed managers meetings to highlight patients, discuss it with other consultants, see if there's any objections, and kind of disseminate information about if the patient is going to be eligible for it. So I think this is a big factor of the everyday aspect of what the research team are doing in order to find patients that are suitable. If you go to the next stage, please. Okay, and then so I think all the others have been about how big the team is really in screening, and then I guess the next two slides are really about patient staff that are coming into ICU, and that includes doctors and actually nurses. So the doctors that come in, and I've been one of these, do not novice doctors training course for ICU, and in that training course, all SepTiC trials are highlighted. So it kind of just disseminates all this information about what's going on within the department and makes you aware that when you're looking after a patient in ICU, you're thinking at the back of your head, like, is this patient eligible for any of the studies? And the same for the nurses that are coming into ITU. If you go to the next stage, please. And these haven't come out so well because it came out of my, they were in my lanyard. So they're a bit sort of dirty, but there's these research credit cards that disseminated to to staff members. So on the back of them, you can see all the different studies, and they give you a sort of basic amount of information. And these are handed out into all the different critical care departments just to, again, highlight it. If you go to the next slide. I think those are the 6 kind of main points I think I came up with. This large team, a lead nurse with 2 associate PIs, so cross cover of the hospital really. This weekend support, screening patients every morning, and then just trying to get as many staff members really involved in what is happening with research in the critical care departments here. I think King's is very lucky in many of these aspects, and I appreciate that other hospitals may not be able to do as many of the things that we do here. But I think if you get as many staff members involved and aware of the studies, then it makes it a lot easier to pick patients up as they come in the door, because quite often that is the best way to do it, and especially so that they don't get some of that exclusion criteria. And Emma is also enjoying something else.
No,
Oh.
I'm okay. Have you finished?
Yeah.
So I think one of the things I would certainly say is how do we recruit patients? Well, we are the ASO group. So we've got anaesthetics, critical care, emergency medicine, trauma, respiratory and orthopedics under our IDU, and we actually support all of those areas. So when you think about what our patient population looks like when they're actually coming to a critical care area, they'll either come to us via theatres or via ED, if you've got an ED department. So our patient pathway, we would see these patients very early on in their journey when they actually come to the hospital environment. So that actually works really well on us flagging. So then we've got iMobile, which is our critical care outreach, and they're essentially a critical care that goes to the ward and works with the patient for 4 hours, 6 hours, just so that they can optimize before they actually come to the critical care area. So we now link very closely in with the iMobile team as well. So these patients are getting flagged earlier and earlier to us from other teams. And that actually is a strength, because what that means is these patients are getting flagged to us, and then we can actually pick up patients that otherwise we would never have picked up. So they'll be looking for lymphocyte counts. They'll be looking at patients coming to ITU with sepsis diagnosis, and then they're already on our radar. So I think that really is a strength. And the biggest strength, I would say, across the board is we do have a true MDT approach to all of our recruitment for studies. So our APIs are amazing, our PIs are amazing, the research nurse and team that's around me is amazing. So that's from a research perspective, but also our clinical teams are strong. And the PI and APIs have done a lot of work being integrated in those areas. And the API scheme has been fantastic. If you've got a really good API on board, they will be there talking about the study, bringing other trainees into the study, and then the more familiar people are with it, the less people are resistant to put people into a study because it's less unknown. So I'd certainly say our MDT approach is one of the strengths of the team, and how our recruitment has been going so well as well. Even just from a safety point of view, through that weekend and through out of hours.
Yeah. I think there's maybe one more slide just showing the team again, but I think that's probably all we were going to say. Yeah.
There they are.
Happy for any questions.
Thanks so much, Miranda, Emma, and Phil, and everyone at King's College Hospital. That was really helpful. I really like the research credit cards as well. Those were quite a good idea. So, yeah, it was just really helpful to kind of hear what's going well at your site. So just to make everyone aware, although King's are open to GMCSF intervention only, but are recruiting really well. So that's kind of one of the reasons why we just thought it might be helpful to provide that insight. But yeah, just want to check if there's any questions for the team before we kind of move on to the other study reminders. Any questions about any other processes or?
However, sorry about that, because what isn't amazing is our tech. As you can see, it's actually constantly failing me here. Sorry, Robbie, can you just repeat what you were saying?
Oh yeah, that's okay. I was just thanking you guys, for presenting, and it's just really helpful for having this insight into what's working so well at your site. And I think, even if everyone gets like a few ideas from it, I think it will really help.
Yeah, and if anyone wants to touch base with us, you're more than welcome to drop us an email and just run anything by us if you think that we can help you at all. Yeah.
We've got a hand up from Geraldine.
Hello, good morning, everyone. My name is Geraldine. I'm one of the research nurses in Stoke Mandeville Hospital. We're currently on setup for the SepTiC trial. So I just would like to ask questions from the rest of the trust, like with the GMCSF. Have you ever encountered like patients actually been discharged within the day 8 that they've been on GMCSF? And if you have, were you giving the GMCSF the IMP yourself, or did you have to train the ward nurses on how to give it? Thank you.
Should I come in there? So Ravi, did you want to cover that from a protocol perspective?
Yeah, so from the trial perspective, we do provide like a one-page summary of training for bedside nurses, and then there's like a training log as well that you can complete, which I feel like, Geraldine, you might have probably already received this as part of your setup. But maybe is your question more of like a logistical point of view, how it works? Yeah, so happy
Yes,
for you to
so
come in on
yeah.
that.
Yeah,
on that.
because it's different if it's in ITU, because I also work in ICU. I'm part-time ICU and part-time research, so I can manage to find time to train the nurses to administer. But if, let's say, if the patient do get discharged to the ward within the 8 days, how does other trusts, if they've experienced it, how did they train, or how do you make sure that whoever's giving the IMP had a training, or do you have to give it yourself?
I can just come in from a King's perspective. We actually don't really see that happen very often in this patient population, probably just because they're a little bit more sick from the sepsis. So I don't think we've ever had it, but what we do is we deliver the IMP if we're on duty. So I don't know, I'll hand it over to the other sites to see what they come up with, but we really haven't seen people get discharged within the 8 days and had to go to the wards to give it, really.
Okay, thank you.
A shameless plug, this may be where your APIs come in as well, especially if they cover lots of different areas.
Not shameless at all. We've got a question from Sarah. She's asking so to you maybe, Emma, how do you manage training nurses on a weekend? So, given that it's a 7-day rota, how do you manage that? And giving IMP particularly on the weekend.
Yeah, so our clinical nurses would give the IMP over the weekend. So what our weekends would tend to look like is on the Friday, we'll look at the bloods, we'll look at the trends, we'll speak to the PI. And then what we do is we hold our IMP. I know that within for the study, you can give the books to the clinical team and say, there's your kind of full 8-day course, but we hold it in the fridge. And then what we do is we allocate out for the weekend. So I'll have a bag with a specimen, and it's got very strict instructions inside that they tick and sign just as a checklist for us that we develop locally. And there'll be a Saturday and a Sunday one, and that actually gets locked into the CD cupboard because that prompts the nurse in charge to support the bedside nurse when they're doing the checks on the weekend. And that's just something that we introduced because that also the clinical team felt that that was something that they wanted to have in place, so that the senior nurses were supporting junior nurses, because we've had this mass recruitment drive, which I'm sure everyone's kind of aware of, that's happening in critical care across the board. So that just made sure that we did have a senior nurse supporting a junior nurse when given an IMP, and it just offers the more junior nurses a bit of support. So then on a Monday, what it would look like is I get them to keep their vials. So they put the vials back in the bag and then they put it to one side. So I collect the empty vials and I treat it more like a commercial study in that way. And then we lock them away. So they're completely locked away in a secure area because obviously it's a GMCSF. And we treat it in that way. So then I would maybe check in, or one of the team checks in, and on Epic, we've now moved to Epic, which is our new electronic health records. And I can check it on my phone and just have a look at the blood results. My PI is probably doing the same thing at the same time before 10 o'clock when we usually have the prescriptions prescribed. And then we'll put a note saying, guys, this is all the bloods are looking great, patient's looking great, clinically stable, give your IMP. So that just gives them the backup of a research team still checking in. And again, that was something that was requested from the clinical team. So when I was looking at setting up the study, we spent a lot of time going through it. Ravi will remember this. We spent a lot of time going through our targets, and I literally broke down this is how many patients will meet inclusion, this is how many exclusions, this is what my staffing looks like, this is what I think we can accommodate. And we kind of negotiated and came up with our targets and figures. And all of those things were including weekend working. We've tried lots of different things around it, but this is what seems to have settled and seemed to have worked for the clinical team. So yeah, it's just using those kind of commercial trial almost strategies to just give those reassurances, and then just be hovering in the background. And then it is just a note saying, as a research perspective, give the IMP on time and things like that. And it used to be that I would call as well, but now I don't need to because they're so familiar with the study. So the more, I think, recruitment that you get, the more confidence your clinical team have in it. I think certainly one of the things that I would not do is pull away if I was having issues with IMP studies. I'd make it more available. And this is coming from someone, so I was setting up a research service in a district general, and they'd never had a research service before, and now I work in a big university teaching hospital. So it's actually looking at the two differences, and I can kind of put them into perspective, where if you've got a smaller unit, that actually has great strength in it. At the moment, we've got 6 units, over 100 patients. So we've still managed to embed it so the clinical staff are getting more confident with that. It just takes a bit of time, is all I'd say. The little credit cards that Miranda was referring to is really useful. I'm sure you've all got like versions of this. When I was doing setup, I actually started doing so this is our new one, and our PI is pretty much always on as well. And I think if you've got a strong PI, it makes such a difference, because the consultants will go to him and talk to him, and they'll negotiate. There he is in the fetching hat on the left-hand side. I'm sure he was overwhelmed to see that I'd put this on there. And he's fantastic, and they trust him, and they know that he's also looking at their patients, and nothing's going to happen to the patients while they're in this study, because that's what we're doing. We're gatekeeping and keeping them safe. So I don't know if there's any other questions that I can help with. I also do check-ins, and I'm sure everyone knows that a pack of Haribos goes a long way. So we do just regular routine sessions. So when I'm bringing up a new study, whether it's in the DGH that we still have, or whether it's in the university teaching hospital that we've got, I'll have just some sweets and a board. And when I'm launching a study, I do a heavy launch. I do a week of launch. So when you were talking about weekend training, I'll go back to the actual question. Sorry, guys. I'll capture everyone in a launch before it opens, and then there's the novice doctor training, the novice nurse training. So I'm actually aiming to capture them well before that weekend time point, and I think that's what probably makes a difference as well. On the weekend, so they have the PowerPoint slide deck, and they've got the paper that they sign. So I always take that paper back. So I leave it in the bedside with the weekend staff, and it's clearly handed over. This is what you must do as part of my health record. This is what you must do, tick, tick, tick. And we're in Epic, and I don't know if you guys have the electronic health records, you can actually set up checklists. So the nurse just has to read and tick what they've done. So have they read the slide deck? Check. Have they signed their paperwork? Check. And it goes through and they check, check, check. So it doesn't take a lot of time for them, because they just tick the box off as a checklist, and then they sign it and it's all done. And then I'll come back in on the Monday, and if someone hadn't signed it, so we've had one person that didn't sign it on a weekend, and what that means is I go back to them, they had read the slide deck, they just hadn't signed the paperwork, and I knew that they checked the box. So they were aware of the slide deck, and they've said that they've read it on a different source document. So they signed it retrospectively to say, yes, I had signed it. It was just an oversight from the paperwork. And then what I do with the logs is I take them back every Monday, and I never leave the wetting copies, all of the wetting copies at the bed space. I scan them and I leave a copied copy, if that makes sense. So I've got lots of different copies, but I'll always have the wetting signature in the site file of every nurse that signed it, and then just blank that's with the patients for the weekend. But I'd say from a weekend perspective, just being proactive is the main thing. And if you can get team days, I mean, pretty much every team day across the board, even if it's online, The novice training is fantastic. I don't know about you guys, but have you got PAD documents where new nurses, if they're doing the critical care course or the introduction to critical care course, there's often a research box. And if you've got a smaller unit and you can manage it, you could actually use that and say, I can sign them off for that. And you could actually do that as a senior nurse and sign off, saying you've discussed the studies. And that might be a good opportunity to make sure you catch everyone as they're coming through as well. So that's what we try and do. Doesn't always work, but the PDNs would be expected then to fill in those gaps. Yeah, it's funny when you do it every day, you don't know what you do really, do you? Is there any more questions? Well, I certainly hope that was useful anyway. But like I said, you can always get in touch with me. Ravi, I don't mind just sharing my email and just touch base with me. You might see me lurking in one of the ICU WhatsApp groups that we've got. And if you're not in them, come in there. We talk about studies such as SepTiC without the SepTiC team there, and get hints and tips from everybody. And that might be really useful to you guys as well. So yeah. Thanks for listening to me.
Thanks, Emma. That was super, super helpful. And I know some sites are moving over to Epic. So I think like Belfast and Cleveland Clinic. So I think that checklist, you know, it might be really helpful if people can implement it from the start.
I can share the templates with people if they've got Epic coming
Yeah.
in and it's looking a bit daunting as well. Good set checklists and templates that you can share.
Yeah, that would be great. Thanks so much. I guess if we'll just move on to the other study reminders. But yeah, if there's any other questions, please do feel free to pop them in the chat. Okay, so just move this along. So I'll just pass over to Janice, who's just going to lead us through some of the recent updates.
Are you still sharing the screen, Ravi? I can't see it.
Yes,
You guys can see it?
I should be, yeah. Not sure, probably Paulina.
Yeah, I can see the slides.
Okay.
I can see nodding of heads, so I think other people
I
can also
can
see the
stop
slides.
sharing and reshare if that's
Yeah.
helpful, Janice. I'll do
I
that.
can't. That's strange.
Okay,
I can't
one
see that.
second.
Ah, now I can. How strange. Sorry, everyone. It's just coming through. Yeah. Okay. So little update on where we are now. So we've got 34 sites open to recruitment across the UK. So thank you very much, everyone who's managed to get open. And we've got over 470 participants randomized, which is an incredible milestone for us. And then we've got a new protocol coming. So if we just move to the next slide, I'll run through a summary of what the new protocol will look like. So we've conducted some review. So the CI and collaborators have sort of reviewed recruitment and screening logs and just tried to update the protocol to help with recruitment and also just maybe remove some misunderstandings. So on the left-hand side, these are items that we've removed. So we've removed the exclusion point that stated that the patient was not expected to survive 90 days due to pre-existing disease. So that has been removed completely. We've also removed the mock-a-blind questionnaire. So after feedback from sites and from patients, we acknowledged that that wasn't a particularly helpful questionnaire for our trial. So we've removed that now. And then on the right-hand side, these are clarifications that we've made. So to the inclusion criteria regarding organ support, we've just updated there in blue. So we've just stated that the patient must require 2 organ supports, i.e. 2 vasopressors, renal replacement therapy, or non-invasive ventilation, continuous positive airway pressure, high flow nasal oxygen respiratory support. So we've just tried to clarify that the patient needs to meet 2 organ supports, and they are listed here. And we've also updated the point that previously stated a source of infection that will require a prolonged course of antibiotics for greater than 21 days. So we've removed that as a generic statement and have updated that just to specific conditions. So infective endocarditis, osteomyelitis, hepatic or cerebral abscess, and tuberculosis. So we've actually listed stated conditions rather than a generic statement of antibiotics requirement. So the protocol isn't active yet, so we've submitted it, it's approved, but we're just waiting for the database to be updated. Am I handing over to you now, Ravi, or?
Yeah.
Yep.
I can take over. Thanks, Janice.
No problem.
So yeah, thanks to all the staff who've sent through their updated training logs. Just kind of a reminder to help us implement the amendment sooner so that we can start using the new eligibility criteria. If you haven't already done so, please encourage your PI to sign the protocol signature page, send through all your updated training logs, and maybe give the R&D a bit of a nudge to send us the approval for the amendment. And then, as Janice mentioned, we've just got the database amendment to implement at the same time. And then the rest of it is, oh, sorry, there's a question. If the trial will consider metaraminol as a vasopressor, which could meet the organ support criteria. Not sure if we've had this
Have we not?
on a FAQ.
Yes, we have had it. 1 second. And yes, it is.
Oh, lovely.
It's on the FAQ. And yes, it says we're classing metaraminol as an eligible vasopressor. So go ahead, Ashley.
Thanks, Janice. It's hard. I've got all these screens open. Can't get the website open at the same time. So just in the interest of time, I might just quickly go over a few study reminders. Just conscious that we've got sites who have been on board for a while, so you might have probably heard this mentioned a lot in previous webinars. This is just, I guess, more aimed more at our newer sites and ones who are just coming on board. Paulina also generates some lovely newsletters every month, and we try and include little snippets of the reminders on there as well. So if there's anything that I've gone over quite quickly, please do check the past newsletters and the webinars as well for some further details. So every month when you get your newsletter, we also send you a screening log request. Just as a reminder that we do actually look at the screening logs quite regularly, and looking at the screening logs has helped with this recent protocol amendment. It helps CI and the other investigators understand the reasons why patients may not be eligible for the trial. So please do try and complete them and send them through whenever you can. We have some drop-down options which are in line with our inclusion-exclusion criteria. So we just encourage you to please use those where possible. And then I guess just a few reminders about consent forms. You're probably already aware of this as part of the NIHR consent training. But we just, when we come to do a monitoring visit, we expect all original consent forms to be signed and filed in the investigator site file, and that you would give a copy to the patient or the next of kin. It's very tempting to see that box and for patients to tick it, but please do encourage them to initial the boxes themselves as best as they can, understanding that some of the patients might have difficulty with their writing. And if there are patients who can verbally consent but have a bit of difficulty with writing, you can use an independent witness to review the consent process, and they will then write the initials on their behalf. And the witness must be independent of the study. And if you do have a patient who doesn't have capacity, or the next of kin wasn't available, and obviously we do have that short time window of 24 hours, so you may have sought professional legal consent, please do try and obtain the patient or the personal consultee consent as soon as possible. Just a reminder about the randomization assignment form. I think some people may be having difficulties with our database. It does take a little bit of time to, I'm just going to pause it. So when you're randomizing a patient, you've got the confirmation page, you're almost at the end, and it can be very tempting to just quickly finish off the randomization process, but this is where things might get a little bit stuck. So this is just a quick video showing you the best practice that we can suggest on randomizing patients so you get your right allocation in the least stressful manner. So imagine you're randomizing a patient and you've got the confirmation page. This is just an example patient. So you're almost at the end. You've put in the date of randomization, which should be on the same day. Then you've clicked randomize, and then you click complete. It's at this stage, before you review your allocation, that we just ask you to hold off a minute and just wait for the system to update. So you can see that the system has had a chance to populate the form with the treatment allocation. You might have to refresh your browser at the top for this to happen. And then underneath treatment, which is the subheading, you will get the allocation. So this is a GM-CSF patient. So the allocation will always be the kit number that you would need to fetch from the fridge. If you're randomizing them to diagnostic or fluid, it will have the appropriate allocation wording. And we have the randomization guidance. We've got troubleshooting guide, randomization video as well. But if you really do get stuck, please just drop us an email to our SepTiC inbox, and we're more than happy to help. Another reminder, once you've randomized your patient and you are going to collect the samples, we provide you with these baseline sample kits. So these are baseline kits that we ask you to collect for all patients in the study. It contains the 3 blood tubes, the white labels which go onto the blood tube itself, and the green label which will go onto the sample shipping form. As we've got quite a few sites open and recruitment is really picking up, which we're quite happy about, please do let us know as soon as you can if you're running low on the kits, and we'll send them out. We do use Royal Mail, so there can be a little bit of a delay in the kits coming out to you. And just as a reminder to check the expiry dates as well. They do vary within the kits, so just before you take the blood samples, please just check the expiry dates. So just to go back, this will be the baseline kit. So this is collected for all patients in the study. And then depending on which interventions they are randomized to, you may need to collect additional samples for the patients. So if you have a patient who's randomized to the diagnostic arm and they have received the PCR and PCT intervention, you'll need to take this 10 ml EDTA purple top tube. So this is why we don't include it in the pack, because not all patients will need it. Similarly, for the GM-CSF patients, they will need 3 additional samples taken. So it should all be documented in our sample manual. We also have a video if you find that helpful to review. But we've got 3 additional tubes to be taken, but that's only for GM-CSF patients. And then once you've taken all your samples and you're packing it up, ready to send it to us, please also complete and include a copy of the sample shipping form within the box. During site setup, we ask you to localize the template so that it's easier when you have the sample, that you're not having to handwrite some of the email addresses on. If it's not legible for our central lab team, it may delay sending the results to your site. And also, two of the requirements for our lab is that they must have the patient ID and the partial date of birth on the sample shipping form. So again, if those are missing and we can't identify which patient the samples came from, it may delay the PCR report results being issued to your site. And then alongside the PCR, we ask you to conduct 2 PCT tests. And this is only required for those who are randomized to diagnostic intervention. There are some requirements, so please do review our FAQs. I've just taken this question from the bottom, but if they didn't have a PCT at the time of inclusion, maybe it was missed or you requested it, but it wasn't done for whatever reason. If you had a PCT done up to 48 hours prior to ICU admission, you could also use that result. And then just a few queries I think that have come about from the PCR reports in general. We just wanted to kind of provide some reassurance. We always talk about the central lab, and you may be wondering who they are and who is processing these samples. So all your samples that you take are processed by the Molecular Diagnostic Unit at Imperial College London. So they are specialists in diagnostic services for the investigation of infectious diseases. And the test that we're using itself is called the SepTiC test, and it is a CE marked PCR in vitro test. So the central lab, they can only provide results based on the samples they receive and they analyze. They don't have any other information about the patients apart from what is on the sample shipping form, so they can't advise on treatment. We ask you to follow the instructions on the PCR report and discuss this with your local microbiology team. And if on the PCR report you have a notifiable disease, this would be the responsibility of the site receiving the results to report this to the necessary authorities, because again, the central lab don't have any other information about the patient. So I'm just going to pause there quickly. I had a question from one of our sites who I just wanted to ask the group how everybody is managing the PCR results with their local microbiology team, or how they're implementing it locally at site. Don't know if anyone from one of the sites have been open for a while. Or maybe I might just pick on John if you're on the call. Let's see. There we go. I can see John.
Hi everyone. Yep, sorry.
Hello.
Yeah, so we just this comes back to the PI, and it's also fed to the microbiologist, and they build it into their sort of daily discussions, which we have as part of the normal unit sort of routine. So yeah, that seems to work reasonably well. Yeah, but I think the key is sort of building it into the normal process as opposed to something weird and separate from normal clinical care. Yeah.
Very much, thanks.
Thanks, John. And I can also see Sarah from Imperial also said the same, that the microbiology team take it into account when they do their ward rounds. and that they inform the medical teams as soon as they receive them and attach it to the patient notes. And I've certainly seen it from monitoring visits. Some of the teams, especially with electronic records, upload the whole PCR report with the patient notes. I won't go too into detail about data entry reminders. We just to say that we don't have any paper CRFs for all of the data entry that we do. So randomization, any SAEs that are reported, protocol deviations or withdrawals, they all need to be entered into our Open Clinica database. We have SepTiC ECRF completion guidelines, FAQs, and also a very comprehensive webinar which was hosted last year and you can find on our website if you want some more information that kind of goes through each day with examples of how to do the antibiotic data entry. And yeah, these I just took them from the FAQs on our website as well. So maybe just as a reminder to just check the website first, and then any questions that aren't on there, then feel free to email the SepTiC inbox. The only paper questionnaire that we do have is the EQ5D. So because it's a validated questionnaire by the Euroqual company, it has to be printed off and completed on paper to comply with how they want the questionnaire to be done. And it also contains a script to aid you with that conversation with the patient. So we ask you to print it out, follow the script, complete the questions, and then enter that data into Open Clinica itself, because our questionnaire on Open Clinica is just the answers. It doesn't contain the full script. And then, you know, as it's coming up towards the end of the year, we thought we'd just provide a quick reminder about the upcoming Christmas closure, but we will talk about it again in next month's webinar and on the newsletters as well. Imperial College the lab will close over the Christmas period, so that means there will be 2 weeks where you won't be able to send any samples to our central lab, but we will be keeping the GMCSF intervention open during this period. We just ask for no samples to be taken or sent during this time. But don't worry, we'll send plenty of reminders before it all happens as well. And then again, just thinking about the Christmas closure, just to make sure that you all have enough bits, boxes and labels, because there'll be a period where we won't be able to send things via Royal Mail, and to make sure you've got sufficient IMP stock in pharmacy and ICU. So we will reach out to all the pharmacy teams as well, just to make sure that you have sufficient IMP. We also ask during that period that you're able to check that you can log into Open Clinica, and we'll remind the pharmacists to check all their sealed envelope accesses. And we do provide some level of database support, but if there is something's really gone wrong with your account during this time, we wouldn't have the other database support available. So we're just preparing for the closure. And just a plug about our next webinar, which we'll have our CI Prof Gordon attend as well. I'm just going to stop sharing.